This meeting is being recorded.
Hey, Fabi.
Hello, 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 everyone. Good morning, good afternoon, good evening, good day. Yeah, we welcome you to our Global Clinical Engineering Week. We are very excited, very happy to have reached to this time, and we are also very anxious to begin or to continue the activities we have developed so far. So let me introduce my colleagues, my friends on this adventure. Firstly, Mr. Jadine David, welcome. Mr. Miladen Poluda, Mr. Tom Job, Mr. Elliot Sloan, and Mrs. Carrie Royce Tabriano. Hello, everyone. Well, in this session, we are going to share with you all the activities we have been developed so far, and we also are going to comment about what we have ahead. And I'd like to begin by comment something about what we have been in the previous days. Yes, it's funny because we began by celebrating a day. This year, we were supposed to celebrate a week, but it was actually 2 weeks. And if we continue this way, next year we will celebrate a month of clinical engineering. That will be wonderful, right? So, okay, let me.
No, it's a clinical engineering year.
Oh, sure. Yeah, it may be in a short time we will have an international clinical engineering year. Why not?
And Fabi, we're going to take advantage of a short opportunity and let Calroy share about the journal just for a moment. She has to run soon.
Sure.
But it's a professional announcement.
Sure, Kelly, the mic is yours.
Thank you. Thank you. It's a real pleasure to be with you today. So thank you for giving me the opportunity to mention that Global Clinical Engineering Journal is the only journal dedicated to clinical engineering. It's Diamond Open Access, meaning that it's offering both authors and readers free access while maintaining high quality peer review and editing processes. We have a very experienced copy editor and also very experienced reviewers who ensure that language issues will be eliminated. So for not native English speakers, this will not be an issue anymore. So we encourage you to send us manuscript and also encourage your colleagues to do so. You can visit the journal on www.globalce.org. The journal has published several issues so far. We have reached our 5th volume. And among the issues, we have some special issues which are dedicated to International Clinical Engineering and Health Technology Management Congresses proceedings. The journal is archived and indexed, and you can submit a manuscript on these following topics. Thank you all so much.
Thank you, Kelly. Thank you. And we also support the encouragement that Kelly says about sending your manuscripts to our journal. It's very important for us to know what you are doing and how you are doing. So having the support of a very, very exhaustive review process, you can be sure that if your manuscript is published, it is because it's a high quality in a very, very important forum for our community. So please keep writing and keep sending your manuscripts. Thank you. Thank you, Kelly. Okay, well, as I said before, we have had a lot of activities in the previous days. And actually, we began our global clinical engineering celebrations since October 15 with a very important event held on India. I am going to share our latest version of our program of this Global Clinical Engineering Week, and only to show you what we have had in the previous day. As I said, on October 15, we had the national meeting in India with the presentation of the EMTC Institute, and some conference where Tom participated with a very, very important presentation, and where there was a very also important announcement concerning our college that unfortunately passed away, Mario Castañeda. Tom, would you like to comment something about it, please?
Sure, and I'm gonna show a picture of Mario. This announcement actually just came out yesterday, and we want people to be able to join. We'll pass this along to you on Saturday, November 12th, in the 12 o'clock Pacific US time. That's 3 o'clock New York time. Anyway, we'll share this information about maybe participating in his funeral. Many of you know and love Mario. 36 years at Kaiser Permanente, was my boss there, but you know, since 2011, when he retired from Kaiser, he was all around the world as a health technology and health IT consultant, just a friend and a mentor to so many people. So, but specifically what happened in India is AMTZ, which has over 110 companies as a part of its organization making medical devices for India there, celebrated the opening of a new teleradiology center, a whole building, of course, dedicated to teleradiology work around that country and beyond. And within that teleradiology center, there's a control room. And that control room was named in honor of Mario Castañeda. And many other honors are coming his way. We're all still recovering from the fact that we lost him here just on October 1 this month. So that's one of the honors that's come his way, is to be named for that control room. Back to you, Fabi.
Thank you. Thank you. And I'd like to take this opportunity to ask you to dedicate some seconds to think of the memory of Marius. Please let have a minute of this. Thank you. Thank you so much. Okay, well, continue with our events, or our past events. Okay, let's share it again. And last week we have several of conferences and round tables organized by the Mexican Biomedical Engineers College in their event called "It's Time for Clinical Engineering." This time they spend the whole week to not only discuss, but also to have a kind of master classes of very specific topics about clinical engineering, and finishing last Friday by celebrating our Global Clinical Engineering Day. It was opportunity to share the success stories about our college in Mexico, and to have a very, very significant ceremony of the celebration. Then we also have another very important event that was celebrated express for this time. That was the CLIC Latam, that is the Clinical Latin American Engineering Conference, organized by ASPIC in Peru. It was a very successful event of 2 days, where our college in Latin America were able to present their success and learn lessons on clinical engineering practicing, by showing how did they get this point, and what they have to share with the community. We are encouraging to continue these efforts in order to have a point of sharing and a point of having these conversations and having this releasing the information that is valuable for all of us. And we also reached to our Friday Clinical Engineering Global Day by having not also the second day of CLIC-LATAM, but a very significant event in Mexico. That was the celebration of the board of the Nuevo Leon's Biomedical Engineering College. This is the third college on biomedical engineering in the country. And we celebrated by having a set of conferences and a very special guest, Dr. Ricardo Silva, that was with us. And we were witnessing the celebration of this agreement on having this college in Nuevo León. And another important event that we have was the Clinical Engineering Celebration Days in South Africa, in Johannesburg, and where Tom Judge also participated with a very important presentation called the Universal Changes that Affect Clinical Engineers. So last weekend, we also have another important event at the Clinical Engineering and its interfaces organized by AveClean in Brazil. It was also a specific event dedicated to celebrate the Clinical Engineering Global Day. And it was very important since they were released some talks and some conferences related to this topic in specificity. After this, for some of us in late Friday, for some others in early Saturday, we have our traditional kickoff event of the Clinical Engineering now Global Week in China, or college in China organizes a very nice and very illustrative event that can be achieved by YouTube in their channel. And with this, we were officially beginning the events of our Global Clinical Engineering Week. So yesterday we had some time to be ready for today, where we had earlier a very important meeting from the Global Clinical Engineering Alliance, where we could appreciate all the value that they provide us and all the members that have joined to this important initiative. We also celebrated the winners of the awards of the Global Clinical Engineering Alliance. And now we are in this overview. And from here to next Saturday, we will have also some other events. In this regard, I'd like to share the mic to Tom's, so he can talk about our town halls. So Tom,
just before I do that, Yadin, would you comment on the GCEA this morning? And I certainly would as well, but go ahead, Yadin, interim president of the Global Clinical Engineering Alliance.
Thank you. We earlier today got together with existing members, National Society from around the world in the Global Clinical Engineering Alliance, and new potential member that joined to better understand what are the mission and vision for the Alliance. We shared a lot of information. All the council members were there to give their opinion, why should you join the Alliance and what we are doing together. And the emphasis was on collaboration. We did discuss the clinical engineering division of IFMBE and the fact that we have strong relationship in working on joint projects together, like the Global Clinical Engineering Day, as you said, Fabiola, so correctly, moving to be a Global Clinical Engineering Week and maybe even larger. So working together have direct results. It provides for opportunity for career growth and satisfaction, and to have better patient care throughout the world. There's so much need there, and we describe it, and there is limited resources. We also looked at some unique features like the not-for-profit foundation that the Alliance has under the leadership of Elliot Sloan that is collecting evidence through funding practical research on the role of clinical engineering in healthcare. So as we look forward, moving from the present to the future, that will be important mechanism to provide additional evidence why clinical engineering is important. And finally, we shared with the world two good news. One was the best wishes received from World Health Organization, from Adriana Velasquez, who everybody in Mexico knows her, and about the collaboration that has agreed to be published today between AAMI and the Alliance about getting together further educational tools and content and share those in multiple languages around the world. So it was an exciting meeting, and I was very happy to see the participation and the engagement. Thank you, Fabiola and Tom.
So Yadin, I saw people from all regions of the world in the GCA meeting this morning. I saw over 30 countries represented. You know, GCA has a focus on working with national societies in particular, you know, whereas CED with individuals and societies. So I saw a lot of energy, and you doubted, you didn't think we could meet for 3 hours and fill it with so much good things, but we were, our cup runs over. So
Right.
I'll have more to say about some other things related, but it was a wonderful meeting and an annual meeting. I think the annual meeting, people want it to be quarterly. So, because there was so much good sharing together. Fabi asked me to talk about these upcoming town halls after today, and I will. Over the weekend, you received some documents. One of them was this, not only telling about the overview session and the 3 meetings, 8 to 10 New York time on Tuesday around capacity building impact measurement, one of our global CE community, 2 of the projects this year that we combined together. One is, how do you have the right people in the right places at the right time in your country and our profession? And then how do you measure not only the short-term, but the long-term impact of our work? And then same time on Wednesday, 8 to 10 New York time, a credentialing focus that's going to be led by Mladen with others' help. And on Thursday, how clinical engineering practitioners are involved in policy, health technology policy, typically at the national level, led by Dr. Elliot Sloan. Also, I point to this document because it talks about our global community together, CED, GCEA, you know, our presence across the world. And Calroy, I think we can fill in these little spots that are empty because we're everywhere, over 200 country now and 600 collaborators between us. But I also gave links to the documents that are going to really matter this week. There's 9 of them here, and these are hot links that you can go and see those documents. I'm going to go to one of them right now, for example, and this was put together by several of us. And it's not only shows how the community works together, but it also, in these project teams we've had, but also introduces a framework that I'm going to come back to briefly in a moment, and the fact that we've had this very robust global body of knowledge, body of practice survey. This slide was prepared by Calroy and I about a week ago. The good news is today there's over 700 responders. Over 120 countries. You remember at our Congress a year ago, we had 128 countries participating. I predict we will have that many countries and more responding to this survey. And you see the distribution across all the WHO-defined regions of the world where people have responded from those regions. And the countries in red being what the World Bank calls LMIC. Almost a half are LMIC. So we work very hard to be in in collaboration and with the hard places of the world, defined by the World Bank economically, as well as those that have a little bit more resources. Fabiola mentioned that I had the privilege of speaking to the GCEA meeting last Friday on Global CE Day. One thing I love about the South Africa National CE Association that Mladen here online and others help lead is that they have a heart. They're very developed, but they have a heart to serve other countries around them. And particularly, you look at Africa, only 3 out of the 27 responders at that point, all these red, other than those 3, were LMIC. So there's many partners and many friends around South Africa, for example, for them to help the national societies and training and many other things. So I'll try to get back here to, so please open these links, and because the other ones that talk about are relevant to these town halls coming this week. Moving quickly here, CBIM Town Hall. So this is analyzing, okay, great, Tom, you got 700, I've shared the goal that we want to have 1,000 responses. And why all the responses matter? Because it allows us to dive deep into a region, as you've already seen, a country, and maybe the provinces or regions or the districts within a country, to know how our practice of clinical engineering varies around the world, and around a country, around a region. And that allows us to start identifying gaps of what people need in those places, to celebrate the successes that they already have, but to find out where there are gaps that they say are important, not that we say are important, and help them address those gaps. So this meeting tomorrow morning, we've got great panelists from around the world. Toby and Baron and Frank and Sean and Antonio and George and Alan, as he likes to be called, Jankun, Ashnafi, Saba, Riyad, and Rosanna and Tazeen. So all of them will be panelists discussing these issues and discussing the data from the survey so far. There's been one other very important survey developed by Saba and Antonio and Shauna and George and others. It's the Theory of Change survey. And once again, what's that about? Well, we have our CE activities. I'll make this a little bit bigger if I can. We have our CE activities, our competencies, as we often talk about, and they lead to improved clinical engineering results, of course. But then how do those results affect short-term patient outcomes in those countries, in those areas? And then long-term, is there a sustainable change in patient outcomes as a result of that? And so this is a new survey that hasn't happened before. The body of knowledge, body of practice has been done a couple times in history, the most recent 2017. So 5 years later, we're looking at that data. And we, by the way, in 2017, we had input from 35 countries and about 200 responses. So we, I want to get 4 or 5 times that this year. And, we're on a track to do that on that survey, but this is a new one. And it's a hard one, honestly. There's a little PowerPoint and Zoom video on how to fill it out, but it's to measure our impact on patient outcomes is not simple, and we know that. But we can point to a couple of the documents you can download, and serendipitously, Lee Ben and I were asked for the Brazil program coming up that Fabiola is going to talk about if I ever shut up here. Later this week, in the next 2-3 days, it actually started today, the program in Brazil, CLAIB SBEB program. But Lee Ben and I were asked to talk about what are the impact on patient outcomes globally and in China specifically. And I pointed to the pulse oximetry at home program in the UK and the AMTZ doing so many different things, manufacturing and maintenance and policy and so forth in India, and the work in northern Haiti by Ray Dalton and others, an NGO service. And you see several impacts on patient outcomes in Shanghai and Hangzhou, China here from these other studies. So, we're beginning to get these kinds of studies that show our impact, during important times. Uh, just a quick side mention, Yadin, at the GCA meeting this morning, there were 2 awards given. The second award for where one country's society helps another country and its society gain traction and gain growth in clinical engineering. This year, it was AIIC, the Italian CE Society, helping many countries across Europe. And similarly, there was a new award from GCEA on how other clinical engineering practitioners, in this case, technicians or technologists, have distinguished themselves, particularly during the COVID crisis. And who was named was Evanel Osias of Haiti, a biomedical equipment technician, very senior, who is doing incredible things with oxygen in the country of Haiti. But he works with and was trained by the NGO called the Ray Dalton Foundation. And so that's serving all the public and private hospitals across a whole region of a country and changing patient outcomes in some remarkable ways. So come and hear more about that in this work tomorrow. And I think, yeah, here's that framework I was talking about earlier that we'll discuss during the webinar tomorrow. You know, how do you measure clinical engineering? Well, through our knowledge, the investment made in us by health leaders and our competencies, right? So, and here's that survey response I was talking about earlier. So on Wednesday, as I mentioned, is the credentialing program. And let me give the mic to Mladen Paluta to talk about that for a moment. Mladen.
Yeah, thank you, Tom. So these are all very important topics in their own right, but of course, as you probably appreciate, they are all interlinked. And I think the beauty of what we do, when I say we, I mean GCEA together with IFMB, CED, together with other stakeholders, we are at a very exciting time, I would say, in the evolution of clinical engineering and health technology management. And credentialing essentially speaks to the need to establish norms in terms of body of knowledge, but also bodies of practice, because bodies of practice will vary from one region to another region, even within one country, and perhaps even within a sector. If we compare private sector and public sector within one country, they could very well vary. So the discussion around credentialing is really a very important one because it impacts us all, either directly or indirectly. So Tom has spoken about the body of knowledge and body of practice survey. We look forward to the results of that. In terms of credentialing, where do we stand now? Well, another number of countries do have credentialing systems in place. One thinks of the ACCE in the USA, which also has got an international arm, the CMBES in Canada, JAC in Japan, the CSCE China, the ISBC India, our colleagues in Ireland, in Australia and elsewhere. And so we are standing on that as a platform because those are in place, and some of them have been in place for some time and successfully so. So the goal now is to set global norms. And when we talk about global norms, one size does not fit all. We need to consider different caters within the clinical engineering family. So we've got clinical and biomedical engineers, as they're called in many parts of Africa. We've got health technology managers, and there's a strong overlap, but not all health technology managers have got a clinical engineering background. We've got technologists, clinical engineering technologists, and of course we've got BMETs or clinical engineering technicians. So all of these have got bodies of practice which are nuanced, as I've said, from region to region and possibly even from country to country within a region. So the challenge is, how do we establish, if you like, a passport that would be an indication that a certain individual or a certain credentialing model or scheme actually meets a norm that has been set by the global CE community, and that's all of us. And so that's really what this discussion is about. So to get there, what we have started already and we will continue to do is to hold regional webinars to define regional nuances, so what is specific to specific regions, and try and get some commonality across the region, and eventually to establish some kind of examination, competence examination, which will be based, if you like, 80% in terms of weight on what we consider as global, universal components of the body of knowledge and a clinical engineering body of practice, and say 20% that talks to specifics, either to a region, to a country, to a sector, or to specific cadre. And we invite all of you to join us in this journey. It is a journey that we're all part of, and I think an exciting one. And for me also, what is very important is to be able to link what is happening in this project, in this initiative, with the other initiative that Tom has already talked about, and the policy initiative, which I believe is next up. So thank you, Tom.
Sorry, I had to get off mute. Great job, Mladen. I was just going to mention that there's some models around the world that this group has looked at, these panelists before, and you can see them from US, Canada, Japan, China, India, and other discussions in our various webinars. Just a small taste of that. Many of you are aware of the certificate program, certification program in India. There's one around, as it shows here, biomedical engineers, but it's really the clinical engineering practice being discussed there. There's one for biomedical equipment technicians, one for biomedical engineers involved in quality assurance, one in project management, and one in manufacturing. So a great list of panelists will join Mladen there on Wednesday morning, New York time. And then another great program, back to back here with policy, health technology policy. Take it away, Elliot Sloan.
Yes, thanks, Tom. We have been talking about policy now for, well, it seems like forever. The health technology is ubiquitous, and during the pandemic, health technologies rose to the very top of public and government awareness. You know, for the first time in our lives, we've heard leaders of government and industry talking about ventilators and oxygen and PPE and many other technologies. So we have an opportunity that's very important for us, the clinical engineering community, to become more front and center in the ongoing public discussion and dialogue. There are many different layers or players in this. The World Health Organization, for example, has long struggled to put health technology to the forefront. It certainly in 2009 became a major key area because of the cost of supporting health technologies and the underlying need for physicians, nurses, technologists, engineers to be prepared to support technology safely and reliably. It is a critical issue. There's a link here provided to one of the global CE journal articles that talks about that. At the national level, many of us have been involved in our country's own FDAs or versions of the FDA or the hospital associations in our nation. And so we have a ongoing discussion, but much elevated and more acutely identified because of the pandemic. And we're going to take years to unwind from the learnings we have from the pandemic. The point is for us to get to the table and be at the table with decision makers. And in order to be at the table, we have to have a different language. It isn't just a technical language. It isn't just a passionate plea for patience. It is understanding the process of legislation and regulation, understanding the language of economics and finance and business development, and also understanding that our field has grown into an enormously complex field. In an earlier session, we talked about robotics, digital health, and so many areas. There are a number of case studies that are available that are posted here to give some examples of the kinds of roles, activities, leadership that clinical engineers have been involved in. And really, I have to give Tom enormous credit for being willing to work night and day with many of the pandemic organizations to develop very valuable programs and policies. And also in India, we have an article and discussion about how India and our colleagues at AMTZ have become part of the fabric of decision making and action with respect to health technologies. Of course, this also goes back to using our body of knowledge survey with information that helps us do a better job pointing to each other and referring to each other in terms of our skills, capabilities, and workforce development needs and opportunities. And I guess of all of the things that we might talk about, the workforce development perhaps is one of the largest areas of challenge, because all of us have yesterday's skills. Some of us have tomorrow's skills. We all have to converge into a suite of skills that meets everybody's needs. There are many panelists who we've invited to participate from around the world. It has really been incredible how on all continents we are seeing leadership of clinical engineers at the Ministry of Health that has emerged out of the pandemic. So I invite you to join us for a couple of hours of discussion about what we should, could, and will do together in order to fulfill this opportunity that lies before us. Tom, thanks very much.
Thank you, Elliot. As I look at what's on the screen, I note that there were 3 references mentioned for this, and Elliot's talked about, well, one of them is the one on the screen in the upper right. Dr. David and I had the privilege of writing an editorial for the National Academy of Engineering that, along with National Academy of Science, National Academy of Medicine in the US, is kind of the highest level of engineering in our country. And the editorial was about the growing role of clinical engineering merging technology at the point of care. And we put forward the fact that maybe there can be new training and workforce change. Maybe there can be new national policy. Maybe there can be new alliances like we talked about with GCEA and CED this morning that can change the way we do business. You may say to yourself, what's the big deal about workforce? Well, if you think like Dr. Manish Kohli, who's one of our physician team members and panelists here, reminded us the way health leaders and ministers of health think about the country in terms of financial investment. Over half of their financial investment is getting the right clinicians, the right doctors and nurses to the table to be involved, because over half the money spent is for doctors and nurses, what I'm trying to say. So if we can help rearrange how care is delivered with clinical engineers taking over certain duties at the point of care in patient care, so the doctors and nurses can be freed up to use their specific skill sets for helping to treat the patient, everybody wins. So that's a big deal. The another reference that I cited that's not shown there is so what countries have done good health technology policy? One answer is Mexico. And Adriana Velasquez of WHO, who came from Ministry of Health Mexico as a clinical engineer before she came to WHO in 2009. In 2004, she created CENETEC, CENETEC, which is the National Center for Health Technology in Mexico, working at a very high level with the Ministry of Health. And in 2022, fast forward 18 years, you will see their work plan there at CENETEC today on how they're impacting health technology policy and care delivery in Mexico. So just a lot of cool stuff in this discussion. I'm looking forward to it, led by Elliot. And I think that wraps it up. So Fabiola, back to you and what's going on this week.
Thank you for sharing this important events that we're going to have this week. And we keep inviting you to register to these town halls, as it will be a very high level discussion that we will have, and we want you to be there. Well, in this week, we will also have some other activities to share with you. And some of them has to do with our Latin America biggest event, that it is the biomedical engineering Latin American Congress that this year is going to be organized together with the Brazilian Biomedical Engineering Society. In this event, we as CED and GCEA, we are going to have some participations during some of these days of this conference. And then tomorrow we will have a roundtable that will be named at the State of Professional Associations in Latin America, the State of Professional Certification Introducing GCEA, with the participations of our college from the CD and GCEA, like Dr. Jadine Davy, Dr. Saidi Khalil, Dr. Antonio Gilbertoni, Dr. Marcelo Lendina, Dr. Ricardo Silva, and myself. And after this, we will have a conference that Tom mentioned it a few minutes ago, that it is an amalgamation of patient outcomes and clinical engineering, global and China lessons. These two events are devoted to show the community from Latin America what we can do together as two organizations working for the same objective, and how our colleagues are looking at these challenges for the next years to come. Then on Wednesday, we will have some poster presentations of clinical engineering tracks by myself, and a special topic symposium related to the profile and models of clinical engineering in the Americas and the Caribbean, with the representations of important personalities from Latin America that will chat about this important topic from the region. Then, in next Thursday, we will have, we are planning to have a video presentations that we are preparing regarding our important issue, important topic, sorry, for the CED. And in next Friday, we have organized, besides another special topic symposium, together with the Division of Health Technology Assessment and his chair, Dr. Murilo Conto. In this session, we will going to talk about the possible collaborations, collaborations between the two divisions, not only for the region of Latin America, but also for all the regions of the world. But since this event is devoted to Latin America, we're going to start by talking about this. But as the Clinical Engineering Division, we will have two webinars, very, very important and very significant webinars that we want to share with you. One is the Welcome to Africa to the IFMBE. As you know, in our last Congress, on our last World Congress, the announcement of having Africa as an official region was released. We were also very happy to hear that, and we want to celebrate it with our college from Africa. So we will have this webinar by sharing the achievements, the challenges, the reflections of important personalities from different societies from Africa. And we will also have another webinar regarding the feminine clinical engineering. We name it the Clinical Engineering Through Feminine Eyes, where I invited to my college, my feminine college and the board, and some other guests to talk about lessons learned, challenges to be faced, and realities concerning women in clinical engineering. We are expecting you to join us in these two events next Friday. And finally, we are going to close our Global Clinical Engineering Week with the CED Award ceremony and special video presentations. In this ceremony, we will officially name the winners of our awards concerning the manuscripts, best paper in the conference, best journal article, the Teamwork Award, and one new award this year devoted to the young clinical engineer. So we have plenty of activities this week, and we can't wait to begin by tomorrow and in these days. Well, and this time we would like to open the mics to our participants to ask you if you have something to share about concerning the events that you may organize, you may think in organizing, or you actually are planning to be released during these days. So I'd like to, sorry, to ask some of our assistants or some of our participants, beginning by our dear colleague Lidina Vicari. Would you like to comment something about what you are on your mind or planning to do on this week or on the next days?
So Ladina, your mic is open, we believe.
Hello, everyone.
Hello.
Hello. It has been a pleasure today following the meeting earlier of the GCEA and all the participants. I felt I had a special emotion during that meeting. It reminds me that October, when we had some live meetings, which has been fantastic. So I enjoyed very much all the participants and all the positive messages regarding this the celebration of this week. And it's always I always feel motivated. It's a feeling that I bring with me every after meeting, which I try to spread and make a difference. But as we know all, it's very difficult. As Elliot said a bit earlier, it's very difficult to convert, to put it in action, to what we discussed to be transformed in a action plan and to make a difference. The difficulties, we know the difficulties around the world, and I'm always, anytime that I have some challenges, I think the same challenges are faced by my colleagues around the world. Lack of recognition of our profession, but I'm happy that now we have the possibility to make ourselves, especially after the COVID-19, to make ourselves to give some credits what we do. Going back to what Fabiola asked earlier, yeah, what I'm trying to do during this month is to spread the word, to try to organize our community, small community in Albania, to make ourselves heard. What we need is what are needed in a lot of countries. Credentialing is something that makes me very happy, and when what I'm going to apply in the application form, what was discussed this morning, is the lack of the program in my country. These two are what I'm trying to work on. So I'll be following these days and the experience of our colleagues and the approach that as a community we are going to follow in order to make the difference, to make us our profession recognized and to make a difference. Back to you, Fabiola.
Thank you, Lidina, for your words. Very warming, and we are always glad to hear you. Thank you. Well, I now invite Mr. Antonio Hernandez, that he may have many things to say about our townhouse and our projects. Please, Antonio, welcome.
Thank you, Fabiola, Tom, Jadine, Elliot, Mladen. I am really impressed for what I am seeing and how through the years we have been advancing in this field that definitely we love it and we have dedicated our life. By the end of the year, it will be for me 50 years working in this field as a professional engineer. And believe me, I have seen advances. At the beginning, it was very, very small improvement, but I will say in the past 10 years has been skyrocketing. And I have always with me two concerns. One was that we do not been allowed to lose our history. And the second one is how we put our knowledge and our efforts into bringing the new generation that we will take care and continue advancing this program and this field in general. And I'm happy to see that worldwide now we have a strong and very committed group of engineers and professionals in general doing this. And I am very sure the future is bright, and definitely I celebrate and I congratulate the effort of all of you in leading this process. We are safe in the future, and once again, congratulations.
Hey, Antonio, we got your history document from PAHO here, and it's one of the 9 documents to download. You want to talk about it just for a moment?
Oh, yes, my concern, because I was at the beginning of the 17th last century, one of the person who has the privilege to start the process in most of the Latin American countries and to document how everything started and what could be at that time the best way to improve and to advance. And that is reflected in an official document of the Pan American Health Organization that was called at the time Maintenance Hospital Equipment, but basically is what we do today. And it will be very nice if some other of our colleagues around the world could write some articles regarding how was the beginning of the health technology management, clinical engineering, hospital maintenance, whatever you call it, because as I say before, we are not allowed to lose our history. And if we don't write it, somebody else will write it for us, or we will forget it. And in that, and it's something that we could measure today, we lost very important experiences. And that will help us, as I say, to avoid the interruptions. I have seen through the years program to start, to stop, to start all over again without any kind of continuity. But fortunately nowadays, with a large group of professionals, things to be growing smooth, and I haven't seen programs stop abruptly like it was in the past. You will find that document that Tom showed you very entertaining, and how was the beginning. Thank you, Tom.
Thank you, Antonio. Always very important, very interesting what you have to say. Well, we are about to finish. We have a few minutes before we finish this session. So this time we would like to open the mics to final comments from our panelists or participants. Please, Mr. Miladen, you share some final comments?
Thanks, Fabiola. Well, I think it's a wonderful way to end, to hear those reflections from Antonio. As he said, he's been in this field for decades, and it's wonderful that he's still part of this conversation and reminding us that we need to link to the past, but also to the future. So, and also to hear Ladina and the passion that she has. So I get energized myself by listening to colleagues such as those, and I think we all do. And so thank you for allowing me to be part of this panel for this meeting. Thank you.
Thank you. Thank you, Mr. Elliott Sloan. Final comments?
Well, I too am very much excited about the discussions we'll have this week, and also about the progress that our colleagues have participated in and created through this pandemic. Nobody could have predicted the crisis that we faced. Nobody could have imagined, honestly, that we would face something like this. And we have worked together. We have learned new methodology. We have been humbled. And we have stood together. And I think we have succeeded in learning and teaching and supporting patients around the world. So I think this is a great opportunity to continue that process and progress.
Yeah, indeed. Okay, Mr. Yatin David, any final comments?
First of all, it's great to see old friend Antonio is talking about 50 years in the field. That's amazing. We don't need to write it down. We just, depending on his memory and everything, will be fine, right, Antonio? I enjoyed the conversation. We talked about the past. We talked about the present. I would like to make a few points about the future. I read articles from a nursing journal last week. And the article says there are about 3.5 million nurses practicing in US hospitals. And now because of the COVID, about 200,000 nurses left the profession. And those who are still practicing, there are 1 million of them that are over the age of 50. So losing about 200,000 out of 3.5 million, with additional 100,000 or a million that are reaching retirement, is give you indication that the capacity and national policies are important. The reason I'm mentioning it is because while nursing has a strong lobby, we clinical engineers never got educated about advocacy, about lobbying, and about connecting with politicians. We, for the many years we practice, believe that if we will do a good job, people will see and understand and appreciate us. But the resources are limited. We do have to advocate, we do have to educate, and we do have to find friends like Ladina and Antonio that understand the political system and help us to make a change in our own profession. How do we make the contact between government, national policy, and the profession? The only country that I'm aware of that make good connection is Japan, where there is a Clinical Engineering Act, that's exactly how it's called, that was passed in 1987, requiring hospitals that are doing certain procedures to have a clinical engineer certified and be employed. That caused the profession to grow, that increase satisfaction on the job, and provide a model for others to imitate, if we will. So one thing I would like to emphasize is, as we look forward during this week on clinical engineering profession, we must change our attitude and realize that we need to be part of political system that usually we don't want to, but we have to learn how to advocate, educate. We have to volunteer to work on standard writing bodies, join the ISO, IEC, AAMI, and Joint Commission, et cetera, and be part of writing those regulations so we can increase the role of clinical engineering and the contribution we make. Secondary, we need to educate engineers about the business aspect of our profession. More and more clinical engineers are facing innovation that can become entrepreneur and a startup company. Unlike before, those opportunities are right in front of us. We have some colleagues like Eric Russell, who became an entrepreneur, was just like one of us, directing clinical engineering in a hospital in Connecticut, and find an opportunity in digital health to create a company. So this is number two, is that we need to introduce entrepreneurship to clinical engineer so they can continue career in that aspect. And the last part I want to make is looking forward is the forensic engineering. More and more, the legal system is telling us what are the norms or standard of care that are acceptable and need to be compliant with. We in the point of care are seeing adverse event. We need to be able not just repair the equipment afterwards if we need to, but also to understand usability, human factor, and how equipment is being deployed in a safe and risk-free condition. So forensic engineering, another area, another direction in the future that we can look at too. And hopefully this week, we'll have opportunity to highlight those. Thank you, Fabiola.
Thank you, Jadine. Very, very enlightening comments. Well, Tom has been sharing many information on the chat, but I'd like to hear his voice in the final comments, Tom.
Two comments. One is what the last guy said, and the other one's I let my fingers do the talking. Over to you.
Okay, thank you. We appreciate your time, and thanks so much for being present on this webinar. We are going to see you tomorrow, so let's stay tuned. Thanks. Good day.
Thank you.
Thank you. Bye, everyone. Thank you
Go to
very
bed,
much.
Lee Ben.
Bye.
Thank you.
Bye.
Bye.
Bye.